Hello, and welcome to ID Talk, Answers from Infectious Diseases Experts. I'm Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson, and an associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. If you happen to be looking at the thumbnail of the podcast, Dr. Price is the dashing-looking one on the right, and I am the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunizations related. Thanks for tuning in today. This is the week of March 10th, 2025. Let's go ahead and jump right into the questions. The first question this week comes from a member who asks, can you review the meningococcal combination vaccine that the FDA approved earlier this week? Well, sure, why not? So, in late February, the FDA approved GSK's new pentavalent meningococcal vaccine, which has been named Penmenvy, which is spelled exactly as it sounds, Penmenvy. So Penmenvy is a product that's pretty similar to the other pentavalent vaccine on the market, Penbraya, if you're familiar with that immunization. Similar to Penbraya, Penmenvy is a combination of the antigenic components of GSK's quadrivalent Menveo vaccine combined with their serogroup B vaccine, Bexsero. So in theory, these aren't necessarily new products, but just a repackaging of GSK's other meningococcal vaccine products. So the ACWY components of the vaccine are the surface oligosaccharide antigens combined with a conjugate carrier CRM197 protein, whereas the serogroup B component is recombinant surface antigens based on the phase 3 trials that have been performed on Penmenvy. The vaccine was approved for use in individuals between 10 and 25 years old and is administered as 2 intramuscular injections given 6 months apart. As I mentioned previously, this approval was based on 2 phase 3 trials that were used to look at safety, tolerability, and immune response in over 4,800 subjects aged 10 to 25 years old. These studies demonstrated similar safety profiles compared to Menveo and Bexsero individually. And when we look at the efficacy of vaccines, remember that for rare diseases where large study numbers would be needed to demonstrate prevention of infection, or in conditions where the disease severity is bad enough that challenge models are not ethical, we use serologic conversion as a proxy for vaccine efficacy. And in particular, the antibody measure that we use is called the serum bactericidal activity, or SBA. Now, these studies demonstrated that in terms of an SBA response, the newer Penmenvy demonstrated non-inferior response compared to Bexsero or Menveo. So at least the phase 3 trials have been reassuring that this product doesn't have any increased safety signal, but still confers pretty good protection against invasive meningococcal disease. When we look at the safety concerns that were brought up, similar to all vaccine products, the vaccine manufacturer GSK states that it should not be administered to individuals with a history of severe allergy, either to prior doses of Penmenvy or to its component vaccines. And then within the phase 3 trials, the most common side effects or adverse reactions that were identified included local reactions such as pain and swelling, but then systemic symptoms such as headache, fatigue, myalgia, and nausea. Again, though, these were not seen at increased rates compared to either Menveo or Bexsero. And then in terms of specific vaccine concerns, remember that Bexsero can have latex in the rubber cap of its syringe, so that's one to be cautious of in those individuals with latex allergy. So the FDA has approved it, but the big next step for Penmenvy is review by the ACIP for inclusion in the CDC recommendations. Now, I think a lot of us have been following the news pretty closely over the last few weeks, but those who maybe don't follow public health or vaccine news as closely as I do may have missed that the ACIP meeting that was supposed to be scheduled for February 26 was canceled. And as of now, we don't have any understanding when that meeting was supposed to be occurring. Now, this is a big issue for the meningococcal vaccines because that was one of the topics on the schedule for this upcoming ACIP meeting, specifically to figure out how the newer pentavalent vaccines were going to be incorporated into the vaccine schedule. Additionally, there was supposed to be discussion about how to address the discrepancy in recommendations when meningococcal AC, W, and Y quadrivalent vaccine is still recommended for all children, whereas the meningococcal B vaccine is still recommended under a shared decision-making model. Unfortunately, because that ACIP meeting has been canceled, it may be a while before we have guidance from the CDC on these questions. However, I think we can look at their guidance currently on the use of Penbria, the other pentavalent vaccine, to get an understanding of how we may be using Penmenvy in the future. Currently, the recommendation is that the pentavalent vaccine can be used in patients 10 years old or older who are going to be getting both the quadrivalent and the meningococcal B vaccine at the same visit. And currently there's no preferential recommendation for use of either the pentavalent vaccine or the quadrivalent plus meningococcal B vaccine at the same time. As we get more guidance from the ACIP and the CDC over the next year, we'll try to address this question on the podcast. And I know this makes the meningococcal vaccines or the products that are available a little more confusing, but I think it's important that we have a broadened armamentarium specifically for meningitis, because when we look at the rates of vaccination among U.S. adolescents, the rates of vaccination against meningococcal B disease in particular is fairly bad, with only 32% of adolescents receiving the first dose and only 13% receiving the full 2-dose series. This is particularly concerning for meningitis B because that is the serotype that most commonly causes infection among adolescents in the United States. So hopefully by having more products, and in particular a pentavalent vaccine where adolescents can be vaccinated against all 5 clinically relevant serotypes at the same time, the hope is that we'll see improved vaccination rates as it becomes a more simple process. But I think time will tell. I think that's enough about the newer meningococcal vaccine, so let's move on to question 2. An AzAAP member asks, considering the measles outbreak in Texas, how can we continue to educate parents about vaccine importance? We'll get into the specifics of vaccination and the importance of vaccination near the end of my response here, but I think it's good first to review measles and then also look at the current outbreak in Texas before we address vaccination. Measles, or rubeola virus, is one of the most infectious agents in the natural world, with greater than 9 out of 10 exposed non-immune individuals developing symptomatic disease after exposure to a sick individual, even among healthy, low-risk children. And in children, mainly because of lack of prior immunity, we know that measles disease tends to be more severe. We know that around 1 in 5 unimmunized individuals end up hospitalized as a result of measles disease. We know that about 1 in 20 children will develop lower respiratory disease or pneumonia as a result of measles. About 3 in 1,000 infected individuals will die from the measles infection, usually due to either lower respiratory disease, pneumonia, or encephalitis. And in those who survive the acute illness, they can experience complications such as encephalitis or secondary infections from immune amnesia, which can last about 2 to 6 weeks after infection, that can lead to long-term health impacts on the patient even after they recover from their acute measles infection. So that's historically what we expect from outbreaks of measles. So what has that been looking like in Texas over the last several months? Well, currently we're looking at about 159 cases reported, with an additional 9 in New Mexico. And at least within Texas, there have been 22 patients who have been hospitalized with measles, which represents about 14% of the identified cases. and there has been one reported death in an otherwise healthy, unimmunized child, which gives us a mortality rate in this outbreak of 0.6%. But again, that's just based on the cases that have been identified thus far. And just to highlight how measles is a disease that disproportionately impacts pediatric patients, within the Texas outbreak, again, there have been 159 identified cases, and of them, 127 are within patients less than 18 years old. So again, primarily a pediatric outbreak. Now, thankfully, within the last week, the CDC has finally announced that they have dispatched an EPI-aid group to the area to try to start controlling the outbreak. And I hope that they're really encouraging vaccination of at-risk individuals, because we know that when it comes to stopping an outbreak of measles, it's really the vaccination efforts that get the disease under control. With regard to measles immunization, the first vaccine was licensed in 1963, and since that time there's been an over 99% drop in U.S. cases, with variations from year to year in incidence, mainly based off of imported cases from areas where measles is still endemic, and because our rates of immunization among young children have varied year to year. Now, the vaccine has been so successful that, as I alluded to previously, measles has been considered eradicated in the U.S. as an endemic disease. Now, despite the vaccine having greater than 95% vaccine effectiveness when administered as a 2-dose series, we still get outbreaks occasionally in the U.S. because our rates of immunization are low enough that if it's imported into a community and the rate of vaccines is less than 95%, we know that there will be ongoing viral transmission, and that's exactly what we've been seeing in Texas and New Mexico. And this is pretty important for us in Arizona to keep track of, because our rates of immunization among kindergartners are low enough, and actually less than 90%, that if measles is imported into our state as a result of the current outbreak in Texas and New Mexico, we may see ongoing propagation and extension of the outbreak here locally. And because measles can spread so rapidly, it's pretty hard to guess when that may occur. So now is the time to really be encouraging families to immunize their child in advance of a possible exposure. This is particularly important because we don't have any targeted antiviral therapies that are effective against the measles virus. So once a patient establishes infection, really it's just supportive care and hoping that the virus and the body's immune response don't lead to severe acute or lifelong complications. You'll hear in the media occasionally people mention vitamin A for treatment of measles, but remember, this is really only critical in developing countries or disaster situations where there's a higher likelihood of underlying micronutrient or vitamin deficiencies. So all that being said, it's always tragic when we have a vaccine-preventable disease that is causing an outbreak like we're seeing in Texas and New Mexico right now, but the silver lining here is that my hope is that it's enough of an urgent, real concern for families that they'll reassess their stance on vaccines. And in particular, when we're dealing with measles, which is highly contagious, preferentially impacts children, including healthy individuals, can lead to a life-threatening acute infection or lead to lifelong health complications, and that there is no effective targeted therapy, and yet we have a safe and highly effective vaccine to prevent disease. My hope is that that packaged message to families is enough to convince them that this is a vaccine that is necessary to keep their children safe. And I think it's really incumbent on us as pediatricians to continue to get that message out there to our patients and their families, and to see a more real-world example of what can happen when that trust in immunizations is eroded. We can look at the Samoan measles outbreak in 2019. Now, if we look at vaccination rates in Samoa historically, they've been pretty good among children, with rates of immunization greater than 90% just a few years ago in 2013. Unfortunately, in 2018, there were 2 infant deaths when MMR was incorrectly reconstituted with atracurium as a diluent, and those 2 infants passed away shortly after receiving the vaccine. Not surprisingly, there was a lot of concern about the safety of vaccines as a result of these two deaths. And unfortunately, those fears were stoked by anti-vaccine propaganda from individuals such as RFK Jr., who personally visited the island just after this event. As a result, the national immunization program in Samoa was suspended for 10 months while vaccine safety was evaluated. Not surprisingly, over that time, vaccine rates among children dropped precipitously, and by 2018, only 31% of infants had received MMR vaccination. And what do we think happened as vaccine rates plummeted? Well, unfortunately, not surprisingly, measles was imported from other Pacific Island nations, and in 2019, Samoa experienced a massive outbreak of measles, which led to 5,697 cases, or 3% of the total population. The nation experienced 1,860 measles-related hospitalizations, or 1 in 3 cases, with about 300 pediatric ICU-level cases, and 83 measles-related deaths, 87% of which were among children less than 5 years old. So that's a pretty harrowing reminder of what infectious diseases looked like prior to routine immunization in the 20th century. So keep talking with your families about the importance of immunizations, and I think leverage the current situation with measles to really let our families know that these are still pathogens that pose a threat to our patients and our children. And so, when we have these safe vaccines that can prevent severe disease and outbreaks, we really need to be advocates for their importance. All right, well, I think that's enough about measles for the time being. So let's move on to question 3. And moving on to the third and final question this week, a member wrote in asking, why have flu cases been higher this year than previous years? Now, the first thing to say here is that there are some experts who would argue that we're just returning to normal respiratory and influenza seasons after they were interrupted by the COVID pandemic starting in 2020. And while there may be some validity to this argument, when we look at the metrics that are followed by the CDC every year to estimate the severity of influenza, I think we can see that this year has been particularly bad compared to the last 10 plus years. So, for example, as of February, over 30% of influenza tests were resulting as positive, which is much higher than previous seasons, suggesting widespread circulation in the community. Additionally, 8% of outpatient health visits over the last several months were due to influenza-like illnesses, or ILI, which is a sharp increase compared to prior influenza seasons. And finally, when we look at outcomes, we know that about 910,000 individuals who have been hospitalized for influenza-related illnesses since October of 2024, which is the most severe in over a decade. And additionally, we know that an estimated 19,000 individuals in the U.S. have died from influenza this past year, including 98 children, which, again, suggests we are having one of the worst influenza seasons we've had in the last decade. And while it can be difficult in the midst of the season to guess as to the causes of this atypical season, there are a few important factors that I think we can highlight that are probably playing a role. So, for example, in most influenza seasons, there is a predominant influenza A strain, whether H1N1 or H3N2, which predominates for the majority of the season, and then you tend to see a small peak of influenza B late in the season. This pattern of circulation usually leads to a scenario where influenza is seen in the United States for about 4 to 8 weeks every winter. Now, contrasting to that typical epidemiology, this last year we've seen both H1N1 and H3N2 at fairly high levels in the community in the U.S., and as a result, we've had a longer influenza season than we would normally see. Additionally, while either H1N1 or H3N2 can lead to severe disease, in general, we tend to see worse flu seasons when H3N2 predominates. And so, because it has been circulating heavily this past season, that also is likely contributing to the severity of the season in general. Taking that one step further, every year the CDC scientists will characterize about 2,000 viruses over the course of the flu season to assess whether or not the circulating viruses have changed in a way that they no longer are similar to the representative vaccine strain. This year, unfortunately, preliminary data suggests that the circulating H3N2 may be a bad match when compared to the strain that was used for vaccine preparation, leading to a scenario where individuals in the community who are vaccinated may not be as well protected against H3N2. And then I think the final piece of the puzzle is that, unfortunately, it looks like this season we're seeing decreasing overall immunization rates in the community. So, for example, in the United States, our goal for immunization annually is around 70% of the population. Now, we've never really done well at getting close to that goal, but this year in particular has been worse than most seasons. So, for example, only 45% of adults in the U.S. have been vaccinated against influenza this season, and about 45% of children. Now, about 45% of adults is a pretty standard number for each season, but typically about 50 or a little over 50% of children are immunized each season, so that is a significant drop among pediatric patients. So in summary, while it's difficult in the middle of the season to really get a good understanding of why we're seeing more disease, I think we can look at overall general trends and say that the high levels of both H1N1 and H3N2, the apparent poor match this year of the vaccine influenza strains compared to circulating strains, and the overall decreased rates in immunization in the community have probably played some role in this season being particularly worse than prior years. Now, last, before I finish this week, I'd like to go back to something I mentioned earlier, and that is the match of vaccine strains against circulating strains each year. Now, so in advance of flu season, there is a group at the FDA called the Vaccine and Related Biological Products Advocacy Committee, or VRBAC, who meet to discuss which strains should be considered for use in the next season's flu vaccine. Now, in the infectious disease world, this is a pretty important meeting, right? Because we want to make sure we have a good match in advance of next year so that our vaccine works as well as possible. Now, if you've been following the news, unfortunately, the VRBAC meeting this year was canceled, and as of now, there is no understanding as to when they will be meeting. My guess is that we'll be using the WHO recommendations for vaccine preparation this year, but that cancellation of the FDA meeting is pretty distressing. And so I just want to say for all of you out there listening who consider yourselves vaccine advocates or advocates for the health of the children in your community, these federal organizations such as the CDC, FDA, and NIH are really crucial in maintaining our public health apparatus. And so make sure you're reaching out to your elected officials and letting them know how important these groups are for maintaining the health of our pediatric population. Okay, and that was my soapbox lecture for the day. And that's it for the podcast this week of March 10th, 2025. Thanks again for listening. Remember, AzAAP members can submit questions for future episodes to id@azaap.org. The AzAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you next time on ID Talk.